Hello, everyone. My name's Jamie Hanson. I'm a consultant midwife and associate professor at Anglia Ruskin University in the UK. And I'm a midwife by background, just 30 years in April.
And would you like to share your screen? And
Sure.
you're being too well behaved.
Just bear with me.
Okay, I'm very sorry, my computer crashed. And so Linda, are you here?
Yes, that's fine, Celine. What I've done is I've done the poll and I've asked Jamie to introduce himself, and now he's sharing his screen. So we're going to let him.
I'm so sorry.
That's okay. That's okay.
Thank you.
Can I just check that you can see the slideshow?
I can see it.
Okay, so I'll make a start. Can I just...
I think we're seeing it in presentation mode, though.
Oh.
Do you have the control, Jamie?
Yes, he does. He's fine.
Okay.
Is it display settings where you have to go into, I think?
I beg your pardon.
That's okay. I mean, we can see it, but we can see other bits as well. Well, I can anyway.
Yes, yes.
Is it the one at the top where it says display top settings?
Hold
The
on,
middle one in the middle?
Yeah, let me just escape. Sorry, just stop sharing.
That's okay. This technology is always a pain, isn't it, really? Especially when you've just practiced it before you came on. Aha! That's it.
It's perfect.
That is it. On your...
Okay, so I'll make a start. I will keep a note of the time. So thank you, everyone, for attending this presentation on Black African women and mental health. And I'd just like to give you a little bit of background to the study. So this study was a research project which was funded by East Suffolk North Essex Foundation Trust, or as they're fondly known, ESNEFT. It took me about 2 months to pronounce all that properly. And it is part of a bigger project which I'm involved in, which is exploring equality, diversity and inclusion within the health authority. So my role as a consultant midwife is exploring equality and diversity inclusion within the health authority as a consultant midwife. And one of the first things I had to do, because there are two parts of ethics, for those that don't know, you've got North and South. And I live in the South, but I didn't really know North Essex very well, which are two areas, Ipswich and Colchester. So I had to perform a scoping exercise because the health authority had said to me, have a look at some particular health equality, but they were not descriptive on which particular one. So I had to, as I've already mentioned, perform a scoping exercise with the midwifery staff, particularly the specialist midwives. It was then agreed that I would look at Black African women's perinatal mental health, which was an important demographic considering the health inequalities they experience. So when reviewing the literature, and this is going to be very brief, because as you can appreciate, the literature is quite vast generally on inequalities and also around Black women particularly and their health experiences. One of the main things around Black African women and particularly their accessing services was around stigma. There is the associated stigma of mental health within the Black African community, which is rarely recognized or discussed. It is seen as shameful and embarrassing to admit to feeling depression, which can often lead to alienation and prevent the women from seeking help from health professionals. This concept is also supported by that notion of actually being that strong Black woman, and the fear of stigmatization is not being allowed, in inverted commas, to be depressed. It is not seen as a visible illness and therefore should be considered a normal part of everyday life. This stigma is further enhanced by a screening tool which we use in the UK called the Hooley questions, which are reviewed by the women as a tick box exercise. And also the women were not often given adequate surroundings to disclose their mental health. And this, along with the stigma, led to further undetection. There is also the fear, a very genuine fear from the women, that if they disclose their mental health challenges, they would be considered a bad mother and have their baby taken away from them. The next area of the literature was around family and community influences, which is sort of linked to the previous one on stigma. There is an understanding within community that there is an ability for women to determine what constitutes a mental health challenge, and understanding that this can be a challenge, a problem, as it's considered a normal part of pregnancy and the postnatal period. There is a reluctance to discuss mental health challenges with family members due to the fear of being judged. As I previously mentioned, it's considered shameful and embarrassing and could lead potentially to alienation within the community. Within this literature, there is also this notion of, or phrase called one size fits all. And this phrase is interpreted as meaning that services are not tailored to specific ethnic groups, as evidence suggests that women who access support for their perinatal mental health found the services culturally inappropriate and inaccessible. The women were often viewed as not like me by the health professionals, and there was a lack of consideration of cultural factors and women's socioeconomic background to enable the most appropriate individualized care for a woman rather than the one-size-fits-all approach. And then we have our governmental reports. One of the ones in the UK, which you may be familiar with, is called MBRRACE, which is Mothers and Babies Reducing Risk Through Audits and Confidential Inquiries across the UK. And when reviewing this report on Black African women, they are more likely to experience adverse outcomes, and 3/4 of women who died during pregnancy had a pre-existing physical or mental health condition. It is also stated that Black women are 4 times more likely to die than a white woman in the perinatal period, and maternal suicide is still the leading cause of direct death in the year after pregnancy. It was felt that improvements in care might have made a difference in the outcome for 67% of those women who died by suicide, which I think is staggering. And this is also supported by the Royal College of Midwives, who have highlighted that women who have experienced perinatal mental health challenges did not receive a formal diagnosis, even when reporting symptoms, e.g. depression. And also, if we look at the cost, the RCM reported that it costs, undiagnosed costs of mental health challenges is 8.1 billion, and therefore further investment is needed in highlighting the importance of mental health, which would be a fraction of this cost. These undiagnosed conditions refer to anxiety, depression, and bipolar disorder, which are common in the perinatal period. And then we have the impact of race in healthcare. One thing I didn't say is I'm in my 2nd year of my PhD, and this project is part of that process. So one of the things that was found was the impact of race in healthcare. Women felt that their engagement with primary care would be considered negative due to the declaration of any mental health challenge being automatically prescribed antidepressants, which the women felt that this would not be effective in treating their symptoms, as they did not want to be labelled as taking medication. The evidence further suggests that Black women are less likely to receive formal care when compared to white British women for perinatal depression, and they have poor experiences and access of services related to mental health. This experience of inequity in mental health services causes a mistrust within the Black African community, which acts as a barrier to accessing treatment and care. Black African women's engagement is a challenge in perinatal care, but it is important that as health professionals, we explore individual circumstances and their social contexts, and which societal forces shape their lives and influences their reason to ask for help. There is evidence to suggest that services are not culturally sensitive, e.g. certain uses of language for mental health challenges. It's also suggested that health professionals have a lack of cultural awareness, which causes discrimination and ultimately a negative experience for the women. There were also considered microaggressions where health professionals perpetuated racial or ethnic stereotypes, e.g. Black women having lower pain thresholds. So the purpose of this study is to explore Black African women's understanding of perinatal mental health challenges and the barriers and facilitators accepting help from health professionals in accessing services. What don't we know? Well, the gap in knowledge that this research project will address is what Black African women in the United Kingdom, specifically SNF, require in accessing services, and what needs to be in place to facilitate the acceptability of perinatal mental health services. So the contribution to knowledge is exploring and describing attitudes to perinatal mental health and its contribution to cultural theory, listening to the women's voices, excuse me, and understanding the service and how it can be improved. So, which finally leads to the research question. So how do Black African women experience current perinatal mental health provision in the United Kingdom and the barriers and facilitators to acceptability of support from health professionals in accessing services? So the methodology was qualitative, and the study design I was using, or is still using, exploratory descriptive qualitative research. This design suited exploring women's views of their lived experiences and from their perspective, and suited the justification for more research in the subject area. Focus groups were used as part of the methodology, which was actually, after discussion with the Black African community, they actually preferred a focus group when compared to interviews. However, I did actually hold semi-structured interviews as well for those women who felt they wouldn't feel comfortable discussing in a group, but also for certain groups of women, it was easier to conduct an interview. And the total sample aimed to be approximately 26 women. So to ensure that the women are sampled are representative of the Black African population. As of today, I've already conducted 2 focus groups and 6 interviews. Just to give you an idea of where I am in the process. The inclusion criteria, so Black African women older than 18 who have accessed maternity services in SNF, and they were all sampled in the postnatal periods for ethical reasons. The sample will also have included women who may not have experienced any mental health challenges, but it's important to get an idea, if they did, what they would need. I also looked at 2 groups of women as well. One group of women who attended a support group, e.g. a mother and toddler group, and those women that didn't. So just to see if there was any comparison or any variation in the 2 groups towards mental health challenges. And the exclusion criteria is all women in the antenatal period and any women diagnosed with a mental health illness. As I've already said, the sample size was approximately 20 women. And for those that have done research, I often find this quite a challenging concept, because sample sizes, depending on what piece of literature you read, which article you read, or which book you read, they will vary. Some will say 5 is enough, some will say 10, some will say 20, some will say 50. It is so varied. But thinking about qualitative research, as you're aware, the sample sizes are not needed to be as big as quantitative. The recruitment. So the recruitment was all women in the postnatal period, and this was, as I've alluded to, was facilitated by accessing community groups. And an organisation I'm working quite closely with is AFIUK, AFRUK, Africans in the UK. So even before I even attempted any sort of data collection, for 5 months, I worked with the African community, volunteering at their mother and toddler group. And the way the recruitment occurred was through gatekeepers. So for ethical reasons, I couldn't recruit. And therefore, the African community ambassadors were recruiting the women for me. The women were also encouraged to self-select by posters and information sheets, but the community ambassadors were the gatekeepers. Ethical considerations. I will be honest with you all, I challenged myself every day in relation to ethics, in relation to the fact that I'm white, I'm male, and I'm a midwife. Okay, and not that I can do this research, should I be doing this research? And so there was a lot of internal conflict that I had to deal with as a white male in being able to undertake this. But for the purpose of the study, the participation for the women was voluntary, and they were provided with an information sheet and consent form outlining the aim of the study, and that they could withdraw any time. Pseudonyms were used to protect the women's confidentiality and assurance given that it would not affect their maternity care in any way. The community ambassadors were, as I've said, were approaching the women and acting as gatekeepers and ensuring that there was no obligation for them to take part. I am aware, or very aware, that some of the women would have been known to me due to volunteering at the mother and toddler group. But during the recruitment phase, it was explained that even though they know me, they have no obligation to take part. So the potential impact of the study to provide an account of the experiences of Black, of Black African women on accessing services for perinatal mental health challenges, and to inform the maternity units on their current service provision. It was also aimed to develop and update guidelines in relation to service provision and the potential need for new and improved models of care to improve outcomes for women. There was also the need for education and training of staff to support cultural competency amongst health professionals. So this is some preliminary findings, just loosely based on some of the questions. So how did your culture impact your willingness to discuss mental health? And the general answer was, I was judged by my family and my mother. In Nigeria, you are meant to be strong, a superhero. How did you feel about discussing mental health? We don't talk about it. It's normal. It's a shame to tell. And what support do you need in accessing services? Knowing where help is and being listened to, a safe space where we belong, a community centre or space. So that's the end of my presentation. I'm going to end the slide slow. And now open to questions. Unfortunately, I couldn't see the chat at any point then because I was presenting, but does anyone have any questions?
Thank you, Jamie, for this beautiful presentation. And I will ask people if they just want to talk and not just write in the chat, so they can undo their speaker and raise their hand. maybe I can ask a question, Jamie.
Sure.
In your study, how will you make the difference between the cultural attitude from the culture and the attitude or of the person related to his race, because she's Black? If she thinks, the way she thinks, is it because of her culture or because of her skin?
That's a really good question, Celine. So one thing that I didn't really go into a lot of detail, which is going to be the second half of the literature review, is going to be around race, and particularly around their skin, around their color. And if you look at the literature around skin and color, a lot of it dates back to colonialism and the historical context. And what you will find is from the women, they will come from it from two angles. They will see it as a collective, as a cultural aspect, so belonging to a culture. But there will also be a group of women who will also be very aware of their skin color. And obviously, this is something that when I have used my epistemology as my foundation for the project, one of the things around social constructionism is race and how that is socially constructed. And it's interesting how when you look at, for example, young children, they usually don't see color. They just see another friend and they might comment on their clothes or their trainers. And it's only as you get older that you become very, very socially constructed. And so has that answered your question, Celine? So yeah, I think there's a really big body of knowledge there around some women thinking of it being as their skin color and some being related to their culture.
Well, thank you very much, Jimmy, for that. And there's some new questions in the
Yeah,
in
I
the
can
chat.
see.
Okay, so let's start with Sarah.
Can I ask, Celine?
Sure.
Have you both got your videos on? Can you put your videos on so we can see you? That'd be nice.
I'm so sorry, Linda. So I didn't even realize it had gone off. Sorry.
That's all right. Celine, you can put your pretty face up as well.
Sorry.
Hey, that's better.
Apologies. Oh, so Sarah said, what were the tribes, country of the women? So Sarah, it varied. So there were people from all different parts of Africa. So there was Nigeria, Uganda. There was all varying different aspects. I've started collecting demographic data, which I haven't really looked into you, but I'd be able to, in a few months' time, be able to give you more information. The challenge is, I found is that within each particular part of Africa, every culture has its nuances. So there are certain things you can generalize, and I hate using that word, but there are certain things that all the women said were similar. But I would argue that within each particular group or within each household, there were nuances. So unfortunately, Sarah, I haven't got the time to be able to look into that into more detail, but that may be a postdoctoral study. There's another question. Sorry, do you want me to take over here, Celine? Sorry, I think I'm taking over. How are the partners supported in the... I didn't really look at that, I'll be honest with you. That would be another study looking at particularly Black African men. That would be really, really interesting. But unfortunately, because of time constraints, what some of the women did say is that some of the women felt that their partners, and the literature support this, were often either potentially the wage earner or potentially just not able to support them as best they could. So, and they would often, like their family community influences, would expect them just to get on with it. How do you think ignorance can affect psychology of pregnant women negatively, and how? Oh, there's a $16 million question there. I think ignorance is a big factor. I think midwives personally, and this is my personal opinion, are so caught up in the day-to-day running of keeping the system afloat because of so many staffing shortages and being able to give the women the best care they can, that sometimes there's certain aspects of that care that often are neglected. And one of them, particularly in my experience, is around culture and cultural sensitivity. I can't see any more questions there unless anyone's got any, or if anyone wants to speak up, please do.
I have I have another question for you, Jamie.
Sure.
Will you look at the differences between the white midwife and the black midwives?
No, I won't be able to, Celine, because of the parameters of the PhD. However, what I can tell you is that some Black African women, some prefer Black African midwives to perform their care, and that could be in the antenatal and postnatal period. However, some, I would say, a lot of the Black African women have told me, and it also is backed up with the literature, that they'd rather not have someone from their own culture or ethnic background for fear of being judged. So it's really interesting. And sort of as an aside issue to this, one of the things I challenged with, I asked the women at the end of the focus group, and unfortunately I didn't record it, but I wished I had. I asked them, how do you feel about me being Black, white male and a midwife actually performing this study? And I had gone in with my own assumptions, thinking what their response might be. And actually, it was the exact opposite. They actually said to me, we're more likely going to talk to you than we are someone that's from our own ethnicity. And I found that humbling. I found that powerful on so many levels. And, you know, I went in with my own preconceptions, which all researchers do. We all go in thinking certain things. There's no way you can eradicate bias, but it's something I struggle with every day doing this project. But the women, I can tell you now, with working with AFIUC, they have welcomed me with open arms. Yeah, so there's a question there, Celine. Sorry, has that answered your question? Okay, sorry, you're on mute.
Thank you.
Okay,
thank you.
So were the women that you're receiving mental health support antenatally? No. Because of ethical reasons, I couldn't really, one of the exclusion criteria were women that were having any sort of treatment or had a diagnosed mental health condition or illness. I was more looking at those women, because what we know from the literature is it usually starts with anxiety, and then that often leads on to other things. Obviously, it's individualized for each woman, but if we were to generally speak, you're looking at things like anxiety, the things like postnatal depression, and we use that word a lot. What does it mean? But also the fact that those conditions, if the women haven't given the opportunity to discuss those conditions and talk about it in a safe space, then that can actually exacerbate the condition, and that's when it leads to people needing mental health support antenatally and often requiring medication. Now, what you'll often find is with Black women, and this is another thing with the literature, a lot of the articles don't distinguish between ethnicities, between Black Caribbean or Black African. So a lot of the time I'm reading these articles and I'm in the dark. So it will say Black women generally, but it won't specifically target particular ethnicities. So I find that Black women generally will often access a service, or they'll come into A&E with a mental health illness. My argument is, why are we waiting till they get to that point? We don't need any more governmental reports to tell us this. MBRRACE are clearly telling us. The WHO reports clearly telling us. There are so many other reports that are telling us that there are so many health inequalities, particularly within the Black population, and particularly Black women, and particularly Black pregnant women. We don't need any more government reports. We now need to do something about it. We need action. Because these women are dying. And I suppose you can hear the passion and frustration in my voice, but these women are dying in front of us. And as I've said in the evidence, they're 4 times more likely to die than a white woman. And one of the leading causes in the UK is suicide. And we've known for a long time, and the numbers are going up. They're not reducing. So, yes, we need to do something now. Obviously, what I'm doing is, with my project, is raising awareness locally. I've also aiming to raise awareness nationally by publication, but also I'm very thankful for being given this opportunity, and I'm very thankful to the Video IDM committee for giving me the opportunity to do it internationally. It's such an honor. Yeah, I agree, Claire. We need action and change.
So, is there a question or even just a commentary you want to share with the people? It's time to connect. This is the theme of the conference, is making connections. Okay, so Jamie, if I understand, your study is from researches on Africa, the continent.
Particularly, yes. So most of the women that I'm looking at in the postnatal period, they've either, most of them are either second generation. One of the things I would like to do is speak to I have had a conversation, but I've not really recorded it, is speaking to the older generation. And talking to the matriarchs of the family and their experiences of mental health. But yeah, particularly the African continent, but with a lot of the women, some of the women have come over as immigrants and some have come over as refugees. So that again brings another slant to it, because refugee women, their risk is even more increased for mental health.
Yeah,
it's fascinating. There's so much I could look at, but I just don't have the capacity to do it. There's so much that keeps coming up that basically is for future studies.
Yeah, you have a commentary and another question.
Yeah. Yes. So the subject, have the subject Black pregnant women. Thank you for that information up there. There was, Gail talked about her experiences. I didn't know much. Yeah, absolutely. Has the subject Black women all been studied elsewhere? Yes, but not. I would say a lot of the studies have been performed in the United States on the African community there, but not specifically on. We know why they don't access the service. What we don't know is how we get them there, if they need it, or what do they need in place to be able to make them to be able to talk about it, because you'll find a lot of the women just need a conversation. They just need to feel safe to talking about it. So it's right about suicide. Yes, that came from the MBRRACE report, which is the UK study around suicide rates. That's a really good question. Do you think there is systemic racism in Africa? Yes. Particularly between different parts, between different tribes, between different culture. So when I talk about culture, so we all have a culture. So we talk about the white culture, we talk about the Black culture, but within that culture, you and I know that you could go into different households, and I think my experience of this was working with the Bangladeshi community as a community midwife. And you'd go into each home and they would all be very different. They would have their overarching similar principles, but there were certain nuances within each. And that, again, was so powerful within. And I just believe that we are underestimating ourselves as professionals and the power that we have, but also the power that we have. I don't believe anyone goes into work to be racist. I don't believe that. But I think there are certain things that are systemic that actually don't actually support certain women. And I think you will get that in any country, irrespective of your nationality.
Thank you for this answer.
That's a really good question, Celine. Really good question. It's a really good question, because it's the things people don't like talking about, and I always like talking about the things people don't like talking about. I think we need to. None of us is perfect, and I think it just makes you think. If I can talk to someone and they'll go away and think about it, that's enough for me. I'm not expecting to make changes in people's personas, but I think if they just think about it, and one of my roles is to do an equality, diversity, inclusion discussion to the midwives on their mandatory training that they do every year, which I was doing monthly, and it was only 30 minutes, but just to get them to think about themselves, and you could see it was very uncomfortable. Really uncomfortable, but it's not comfortable, it's just to make them think about themselves as a person, and then also about the women and their families that they care for.
Yeah, it's about caring. Is there another commentary or question for the participants? Yeah, I love that. And Jamie, I wish you courage.
Yes, thank you.
Continue to have your ethics and your rigor in your research is very, very important. And I look forward to read your research, your thesis. Yeah.
Thank you very much.